Okay, I see it here. Yeah, okay, great. Also thank specifically more Mr. Dr. Yuam, my close friend and long history of friendship with all the team sitting on the front here. I'm talking about current concept, but I would like to start by, going back to the history a bit and get you to the current status. I have nothing to disclose for this presentation. I'll try to, as I said, go back to the history from where we were before and where we are now, and then give you some summary about GLP-1 receptor agonist studies, and the combined agonist GIP, GLP-1 receptor agonist as well, and then comparing between the two important that currently we are talking about, tirzepatide and semaglutide in SURPASS-2, and getting this into the Incretins' role in the current guidelines, the recent guidelines we are, and leave you with some taking home messages. So going back to the history, 1902 was the first time we start knowing about hormone. The first hormone was secretin, and from that time, we endocrinologists start to have some business about endocrinology. So the first hormone was secretin. 1906, Benjamin Moore hypothesized that a gut extract, actually taken from the duodenum, it seems to be, contain a hormone that regulates the endocrine pancreas. And in patients with diabetes, they have lower glucose and found that have something in benefit on reducing the sugar, as shown in urine sugars reduction. And this is the paper, 1906, published by Benjamin Moore. And that is in 1906. And you can see here the extract of duodenal mucous membrane. And as you will know later, this is a part where one of the incretin is secreted from. 1929, more specifically isolated a fraction of that gut extract, and in animal studies showed that this reduced the glucose, and from that they postulate that this stimulates the endocrine pancreas to secrete insulin, and that factor came the name incretin in a way that it is an intestine secretion insulin, and that's where we started with the name of incretin. Later on, after knowing how to measure insulin, they started looking into the insulin effect if somebody is taking glucose IV or glucose orally. And you can see in the dotted line, this is an oral glucose infusion to the patients. And on the straight line, this is the one which is IV. Clearly, you can see the plasma insulin level is higher with the oral glucose infusion. And you can see it's extended even for a longer period with a higher level. As I said, it was extract from the genome, and then they start to know more about it, and that extract after isolation turned to be what we call it now, gastric inhibitory polypeptide. And you can see from the study, they start using it into study about the glucose and insulin response. And you can see that the changes in plasma glucose and the insulin, let's take the glucose first on the left, you can see if you give them IV glucose with GIP, the incretin, you can see that the glucose is lower in the dark dots, and while the glucose is higher if you don't give them GIP, which postulated to increase insulin secretion. Same thing, you can see that insulin is higher when you give GIP on the insulin on your right side. And this is a human study, although not many people, as you know, at that time, studies were not that easy. And this is the famous, probably, paper and study that you know from Michael Nock, who looked into this incretin effect that we can see on the left side. On your left side, this is the control subject. You see the incretin effect between the oral versus the injection, the IV. And you can see on the right side, the type 2 diabetes, they looked at them and they found this incretin effect is diminished. Whether you look at the, the insulin or whether you look at the C-peptide. Clearly, there is a diminished incretin effect in type 2 patient with type 2 diabetes. So from that time, they started looking into how to treat our patients, since we know about the reduction in this, effect of the incretin in our patients. And again, we talked about GIP that started first and excitement about it, and later on they have the GLP-1 found to be much more stronger effect than GIP. And from that time, GIP was neglected actually. Not many studies have been done until you will see recently there was an importance again on GIP came afterwards. So GLP-1 found to be the more powerful than GIP, and from there we started talking more about studies of GLP-1 receptor agonists, as we will hear later on. So we have the GIP from the upper gut, from duodenum, K cells, GLP-1 from the lower gut, L cells. And both of them, if you add them together, probably 2 to 3 times more powerful when you give oral to increase the insulin secretion from the pancreas. I just show you this slide just to compare two things. I mean, it's a busy slide. GLP-1 on your left side and GIP on your right side. I have put a star on two things which I think are relatively relevant for us here, is that glucagon is increased by GIP while it is reduced by the GLP-1. And the second thing is the GI effect is not prominent in GIP when you compare it with GLP-1 receptor agonist. And this is the timeline of the discovery. 1987, first GLP-1 become the incretin hormone. 93 DPP-4 was, we're using it in inactivating GLP-1 and increasing the response to controlling the sugar. 1996, inhibiting food intake was found, and that's starting the importance about weight reduction. 2005, the first GLP-1 receptor agonist approved for type 2 diabetes, even before the DPP-4, which is followed a year later. 2012, first once weekly approved for type 2 diabetes. 2014, first approved for obesity. 2016, first positive cardiovascular outcome trial found to be on one of the GLP-1 that we'll see later on. And 2019, first oral, you heard about it, oral semaglutide was approved for type 2 in 2019. And recently, 2022, we have the combined agonist, which is GLP-1 and GIP, as we will see also later in more depth. So it's a big topic. I cannot cover many things. So I try to summarize a few important things, and mainly really the issue about the important thing that we are now currently in use, especially in some of the countries that are available. I hope it's available in your countries. So the importance of the studies of treating diabetes started to be focusing more of the outcome of cardiovascular outcome studies. And here's I'm highlighting in colors, in green color, the studies, and down you can see the molecule used in Sustain 6, Leader, Harmony, Rewind, and Amplitude. These are cardiovascular studies that were superior, found to be superior, not necessarily safe, but also superiority they have. And here are the, down you can see liraglutide, semaglutide subcutaneously, albiglutide, liraglutide, and one in new, which is not yet, I think, available or FDA approved, effiglitide. Down, Elixir, Freedom, Pioneer 6, and Excel did not show that superiority, but they were safe to be used. And this is a meta-analysis slide showing the whole, all of the group that here, about the cardiovascular outcome trial. And I highlighted again in a green rectangle for the ones that really showed superiority. Again, Leader for liraglutide, Sustain 6 for subcutaneous semaglutide, Harmony for albiglutide is not used, not anymore available. Rewind for dulaglutide, which is available. Amplitude for the new drug effiglitide, which is not yet available. But these are the ones who showed really superiority in cardiovascular outcome studies and protection. Again, the important subject is a big one. I cannot talk about everything, so I'm going to focus on the more recently, what we are using really, semaglutide, because of the more beneficial effect we are seeing. So we have two things. We have subcutaneous, which is called Sustain studies, and we have the oral semaglutide, and the study is called Pioneer. In addition to Sustain 6 that we show about superiority in semaglutide 1 milligram subcutaneous injection, these are the other studies. You can see many studies there, starting comparing with monotherapy, with oral agents, with other GLP-1 they compare it with, add-on SGLT2 inhibitor, add-on basal insulin. All these studies looked into first HbA1c reduction. You can see in all of them there is significant reduction in HbA1c compared to the comparator. And if you look at the body weight reduction, and you can again see that the weight reduction is significantly going with all the, whether it is even semaglutide 1 milligram or even the lower dose 0.5 milligram as well, they are significantly better in weight reduction compared to the other comparators. Now, this is the oral agent, which is oral semaglutide, Pioneer 1 and 5, 7 to 8. These are looked into this. Again, For the study of the, I think I didn't mention it, the Pioneer 6, did not show superiority for the oral, but the subcutaneous shows superiority on cardiovascular outcome. Here, looking at the other studies, Pioneer 1 to 5, 7 to 8, and looking into, again, change of HbA1c compared to the comparator monotherapy, empagliflozin, sitagliptin DV4 versus LIRA and placebo, renal, flex, and insulin. Clearly, you can see the significant benefit on HbA1c reduction. And if you look down to the lower part, you can see the change in body weight. And you can see, again, they are significantly lowering the weight compared to the comparator. I would say probably with the empagliflozin, there was a reduction, but there was not significant level. I'm not going to talk about this because it's more of focusing of weight reduction, and it's a big topic, but I just want to mention that there's semaglutide 2.4 milligram, which have been studied, as you can see, called step 1, step 2. Some of us, and maybe you guys, been involved in these studies. Step 2, step 6, we're having some people with diabetes, but because of time, I will not mention that, except to say that in 2021, June 24, because of these studies, Wegovy, what they call it, semaglutide injection 2.4 once weekly, was approved for weight management, not only for diabetes, in people with diabetes, with obesity or overweight, but having another related, risk like high blood pressure, type 2 diabetes, or high cholesterol. But again, with my experience in, for example, in UAE, you are not supposed to give it to somebody with diabetes. It will not be approved even by the insurance. And this is the new one, which is not available. I don't think it's yet approved to my knowledge, is epiglitide, also another good one, seems having cardiovascular outcome. This study showing the slides of incident of MACE. Clearly, it was significant and superior with regard of incidence of MACE. Expanded MACE, also they looked into that and found, again, it is superior here. Again, there was some good things about the renal composite outcome event, and also MACE or death from non-cardiovascular, all were superior in their benefit here. So let's move now to the new molecule, which is a combined agonist, GIP-GLP-1 receptor studies. And these studies called SURPASS, starting from 1, 2, 3, 4, 5, 6. Not yet, as you heard from our distinguished speaker in the morning, the keynote speaker, that the cardiovascular outcome of SURPASS CVOT, they call it, is not yet completed. And I think what he said is extended, and maybe we'll come to that in another slide later on. So in this slide, they're comparing SURPASS 1, for example, versus placebo, monotherapy, 2 drugs combination. So they have, again, always they try to do many studies to compare different things. And if you go to the result, you can see they're always having beneficial. For example, here they compare usually tirzepatide 5 milligram. Probably that 2.5 is the starting dose, but 5, 7.5, 10, up to 15 by 2.5 increase. But always all the studies looking into comparing tirzepatide 5, 10, 15 with the other comparator. And now in this study, you can see, the studies, all of them, 1, 2, 3, 4, clearly you can see significant HbA1c changes from baseline in all of them, and significantly with the higher dose, the better effect. And again, here's for the weight changes from baseline. Clearly, again, the higher the dose, the better. Even the lower dose is better than the comparator in most of these all studies shown here. This is an important slide for the approval process. So CV meta-analysis of SURPASS phase 3 study, they looked into that and they found it is safe. It's not the perfect study for CVOT, but they used this one to approve the drug for use, and for that reason, May 2022, approved by the FDA by the name of Mounjaro, and to be used for diabetes management. This is what we have seen earlier, and this is what you heard, some of the studies that are coming in the future. SELECT is already completed. SELECT is about semaglutide 2.4 milligram. It's a CVOT, a non-diabetic, and it was completed and showed some good effect, as we heard. And then you have the flow study of the renal, again stopped apparently earlier. I think there is good result. It's not yet published. the flow, then the sole CBOT about the oral agent semaglutide, and this is still not yet completed, expected again, most of them expected to finish and publish in this year. And surpass CBOT about tirzepatide, again, as we heard, it is going to be extended further, but this is mean we are talking about expectation about 10th October 2024. Now, after this, I will just summarize to you here. From this slide, US FDA approved indications for GLP-1, and actually not only GLP-1 because tirzepatide is a combined one here. From the first line on top, glycemic control, all of them are approved to be used as medication for diabetes management. For weight loss, liraglutide is approved for weight loss, semaglutide for weight loss, and recently in November 2023, tirzepatide was again approved for the use in obesity, not necessarily diabetes. And for the MACE and with risk factor or established disease, again, liraglutide, and also you have the dulaglutide, semaglutide with the people who are established disease, and again, not yet for tirzepatide because we are waiting for the CBOT trial. So moving now to compare to what we really now having in the market, and they are competing very heavily with each other. And I'm not sure if you have it in your country here or not. Tirzepatide I'm talking about, now it's available, very good. So you'll have the experience probably like us. So this is a study SURPASS-2 comparing tirzepatide with semaglutide, but again, they're comparing not with 2.4, they're comparing with 1 milligram, okay? So, and you can see from this, I would not go into the details, but 5 milligram compared with 10 milligram, with 15 milligram, and semaglutide 1 milligram. People with type 2 diabetes having A1C 7 to less than 10.5%. They should be overweight and stable weights. They should be on a stable dose of metformin, more than 1,500 milligram per equal or more than 1,000. And these are the exclusion criteria of that study. First, let's look into the glycemic control. Clearly, they started with a higher level of HbA1c of 8.28%. And even with all of the molecules, starting with semaglutide 1 milligram, it went down at the end of 40 weeks of the study, 6.4%, achieving the most common target that we look into. And then the others, as you can see, even doing better, 6.2%, and the higher dose, 5.8% after the 40 weeks of the study. And clearly, when you look at what is your target, and now we're talking about some less than 5.7% these days. We were never talking about this before, starting before with the 7%. Some of the aggressive people like us may be here doing 6.5, and now we're talking about less than 5.7. You can see, if you're looking at the 6.5%, the higher dose 15 milligram of tirzepatide, 87% of the people in the study achieved that. And if you look at the even more aggressive control, which is less than 5.7, more than half of the people who took 15 milligram achieved the target of less than 5.7%. Here is the important part also, the body weight. And again, these are people with diabetes we're talking about. So over time, for the 40 weeks, semaglutide, they started with a BMI of 34.2, about 93.8 kilogram, the mean of the study. And you can see that semaglutide 1 milligram reduced to 87. And then you can see with tirzepatide, the more higher the dose, the more better beneficial effect on weight reduction. And more importantly here, and I don't see Dr. Amer if he's here to see that we are going to, close the gap between the surgery they have and between medical treatment. You can see the benefit of weight reduction. Looking at, let's say, 10% or more of weight loss, 65% of the people participant in the study achieved 10% or more, 15% or more achieved even by 40% of the higher dose. And you can compare it with semaglutide 1 milligram. It is there, but it's not really comparable. It's less. Side effects, really nothing much, to compare between the two, nothing really significant or really contributed. There is maybe some, if you can see here, some increasing of pancreatic things, but it's nothing really significant. And I will probably move now to talk about what we heard and their role in our recent guidelines. Starting with the ADA guidelines, looking at the efficacy, again, we're talking about the two molecule or the two groups, GLP-1 first. Efficacy is high to very high, and GIP combined agonist with GLP-1 is very high. If you look at the weight change, again, clearly GIP and GLP-1 is stronger, very high, and that one intermediate to very high. Importantly is to look into the benefits on the cardiovascular and the renal outcome. So looking at efficacy, effect on MACE, the benefit is shown in not all of the molecule of GLP-1. It is shown, as we've probably seen it earlier, dulaglutide, liraglutide, semaglutide, and the others were neutral effects, so they were not superior there. If you look at the progression of DKD, again, the beneficial on the renal with the same molecule, but they were only depending, at least at this time, on the albuminuria benefit, which improved the outcome on the renal outcome because of the albuminuria benefit. If you look at the lower GIP and GLP-1 receptor agonists, which you have now tirzepatide only, we are still waiting to complete these studies, and we can talk about it when we hear it. Hopefully, it is positive result, as we heard of some of them preliminary. Now, so this group, GLP-1 with the proven benefit CVD or SGLT2, now comparing what's available in the guidelines, which one we should use, whether it's atherosclerotic disease or high risk for cardiovascular, they are equally, indicated. GLP-1 receptor agonist with a proven benefit, again, you have to know about the one we mentioned, or SGLT2, again, with a proven benefit is your choice. Now, sorry, one second again. Yeah, I forget to mention the CKD here. Again, here is an important point. The CKD, no, it is really the SGLT2 is superior in the benefit, at least this guideline. They prefer to use SGLT2 unless you have contraindication or you have intolerance to it. Then your choice would be GLP-1 receptor agonist. Again, when you treat your patient, you need to look about not only all these things, but also glycemic control. So if you look at the glycemic control, you can see that the very high beneficial effect is from dulaglutide high dose. I don't think we have it. I'm not sure you have it. The 3 milligram, 4.5 is not yet available. They were studying it. I think they were before in the US probably. And then if you look at the very high, you can see the combination or insulin also again included in this group. And if you look at, again, this is glycemic control, so semaglutide, tirzepatide is among them. Dulaglutide, since it's not available, I don't think we need to think about it now. And again, when you talk about treating your patient, you need to think about weight reduction as well. There's more emphasis nowadays into weight reduction when you treat your patient with diabetes. So again, when you look at the efficacy, for weight loss, very high is the two that we looked into, semaglutide and tirzepatide, and also followed by liraglutide and dulaglutide. I just move here to a short, points about comparing this ACE guidelines, which I have some differences, and I think I'll tell you my opinion about it. So talking about cardiovascular or high risk for cardiovascular, I think they agree with the ADA. They are both saying you can use either a GLP-1 or SGLT2. Now, when you go to the others, CKD, they said SGLT2 or GLP-1, and I disagree with that, at least in my opinion. Maybe my colleague agree with me with that. I still prefer SGLT2 with the CKD, if can be given. For the stroke, which is something interesting here, for stroke or TIA, GLP-1 clearly is your choice, but also pioglitazone have shown to be beneficial as a secondary prevention for stroke and CVAs. So we're going to end with my take-home messages, and I think I'm doing well, Mr. Chairman, with the time. Okay, so just these take-home messages for you. I mean, GIP and GLP-1 from the, this is from the upper, the second one from the lower, are the really incretin hormones known and studied more than others. Others are also, there's a lot of things going on in this study, but these are the ones that we already know more about. Combined GIP and GLP-1 receptor agonist tirzepatide weekly injection was more recently approved for glycemic control. And for established cardiovascular indicator for high risk, GLP-1 with demonstrated, again, emphasizing that it has to demonstrate cardiovascular disease benefit, which are mentioned here again, dulaglutide, liraglutide, and semaglutide is recommended. The benefit on the renal, again, endpoints driven by albuminuria benefit effect demonstrated again, it seems that they are similar. Dulaglutide, liraglutide, semaglutide, waiting for tirzepatide, but we don't have the evidence yet. Although I heard they started early because there is some beneficial effect. As part of the holistic approach to diabetes management, there has been great emphasis on weight reduction in addition to the glycemic control. So medication for type 2 diabetes with very high efficacy for glycemic control and weight reduction, including the two molecules that I probably talk more about, semaglutide and tirzepatide. And with that, I would like to stop here and thank you for listening. This is a view from Bahrain. I think you know where it is, right? I just have it last time. I kept it to show that I already been here before. Thank you.
Thank you very much, Dr. Ahmed.